أهلا وسهلا فيكم ومساء الخير. أنا لما قنواتي. I am a doctor in pharmacy and I am an ICU clinical specialist. هاي البرزنتيشن هي جزء من عدة محاضرات هي حتكون مكثفة على العناية المشددة، ومعظمها راح يكون للأطباء، بس كمان هي مفتوحة لكل الناس بسامس. في عدة محاضرات راح تجي من سامس فارماسي اسمبلي، هن الصيادلة، هن الأعضاء بسامس. وهي البرزنتيشن اليوم راح تكون بالإنجليزي. البرزنتيشن حتكون 50 دقيقة، وبعدين في عنا حوالي 10 دقائق بالأخير مشان الأسئلة. إذا ممكن تستنوا وتسألوا الأسئلة بآخر البرزنتيشن وترفعوا إيدكم، وكمان شوفوا إذا عندكم سؤال على سلايد محددة، شوفوا رقم السلايد مشان نركز عليها. Okay, so we're going to start. Today's presentation is on sepsis, early signs and immediate actions. And the presenters are going to be myself, Lama Kanawati, and also Dr. Nahla Hachmi. Dr. Hachmi is a doctor in pharmacy, and she is a clinical pharmacist in emergency medicine. And Dr. Hachmi is going to start.
Thank you for the introduction, Dr. Lama. Assalamu alaikum jami'an. My name is Nahla Hachmi. Like Dr. Lama mentioned, I'm an ER pharmacist in Orlando. We're going to start with a disclosure statement. So no one in a position to control content has any financial relationships to disclose. We're going to start first with the presentation objectives. So first, we're going to be starting and describing the pathophysiology of sepsis and septic shock. Next, we're going to move to identify the screening tools and goals of resuscitation. And finally, we're going to select appropriate fluids and pharmacotherapy for management of septic shock. This is a slide of abbreviations that we utilize throughout the presentation slides, so please refer back to it if you have any questions. So definitions. Sorry, give me 1 second. Sepsis is a life-threatening condition that arises when the body's response to infection causes an injury to its own tissues and organs, while septic shock is defined as a subset of sepsis in which risk of mortality is substantially increased and characterized by refractory hypotension despite adequate volume resuscitation. Patients with septic shock requires the use of vasopressors, and the presence of lactic serum greater than 2 millimoles per liter. Now, speaking of numbers, sepsis and septic shock are major health problems impacting millions of people around the world each year, and they kill around 1 in 3 and 1 in 6 of those that it affects. Speaking of pathophysiology, during sepsis, systemic immune activation triggers cytokine storm, leading to fever, shock, and organ failure, while the adaptive immune response generates pathogen-specific antibodies and immunological memory. Sepsis-induced immunosuppression causes immune cell apoptosis, functional exhaustion, and reduced CD4 and CD8 T cells. Together, these processes contribute to septic shock that is characterized by leaky capillaries, which is an increase in capillary permeability to proteins, resulting in the loss of protein-rich fluid from the intravascular to the interstitial space. And overall, it's defined also as a low systemic vascular resistance, vasodilation, and low blood pressure, and finally is the shock station. Moving forward to talk about the sepsis screening tools. Sepsis screening tools are designed to promote early identification of sepsis, starting with the SIRS, which is an exaggerated defense response of the body to an anxious stressor, such as, naming few examples, for example, infection, trauma, surgery, malignancy, etc., to localize and then eliminate the endogenous or exogenous source of insult. Now, SIRS has certain SIRS criteria are many, and patients must meet two of the following of the criteria to meet the SIRS criteria. So number one, we have temperature greater than 38 Celsius or less than 36 Celsius, heart rate greater than 90 beats per minute, respiratory rate greater than 20 breath per minute, or partial pressure of CO2 less than 32. And then finally, we have white blood counts greater than 12,000 or white blood counts less than 4,000, or we have greater than 10% bands. And that will bring us to our first assessment question of the presentation. All of the following are SIRS criteria except. I'll give you a moment to think about it and we can move forward with the answer. So we can move to the next slide. So our answer will be the low blood pressure, which is defined as a systolic blood pressure less than 100 or equal to 100, while the rest of the answers are the SIRS criteria that we just discussed. Moving forward to the next screening tool assessment, we have the SOFA, which is a tool used to assess acute severity of illness and correlates with the risk of ICU mortality. It is a composite score based on the degree of dysfunction in 6 different organs, including respiratory, coagulation, hepatic, cardiovascular, central nervous system, and finally renal. Each system is scored from 0 to 4, with higher scores indicating more severe physiological and biochemical abnormalities or greater intervention needs as well for those patients to be done. A SOFA score of 2 or more defines sepsis and signals significant organ dysfunction. And the chart is there on the slide for your reference. The Q-SOFA is a quicker assessment tool. So it uses 3 criteria, assigning 1 point for each. So we have a low blood pressure, which is defined as a systolic blood pressure equals or less than 100, high respiratory rate, which is equal to or greater than 22 breaths per minute, and finally, altered mental status, which is defined as GCS score less than 15. A value of 2 or greater indicates severe sepsis. However, this tool has high specificity and lower sensitivity, and it's not recommended to be used as a single screening tool in sepsis patients. We have the Muse assessment screening tool, which is composed of a bedside measurement of heart rate, respiratory rate, systolic blood pressure, temperature, and level of consciousness. And the level of consciousness is defined as alert, responsive to voice, responsive to pain, or unresponsive. This tool assesses the degree of illness of patients using 4 physiological findings and 1 observation. And a score equals to 3 or greater means it's positive. The next assessment we have, or the next tool assessment we have, is the Muse, which is based on 7 easily obtained clinical parameters and produces an aggregate score from 0 to 20. It detects deteriorating patients in hospital, specifically in those at an increased risk of ICU admission, cardiac arrest, or death within 24 hours. And we have a positive score equals or greater than 7. Now, we're not talking about these scores, the last 2 scores a lot, honestly, because the recommendations per sepsis guidelines is to against using the Q-SOFA compared to the SIRS, Muse, or Muse as a single screening tool for sepsis or septic shock. And the Q-SOFA has like we discussed earlier, has a poor sensitivity and can be used to alert the clinicians for possibility of sepsis. But other scoring tools such as SIRS, Muse, and Muse are preferred. Now, this is the recommendation by guidelines. However, in real practice and in real world, we actually use the Q-SOFA and the SIRS the most, and we don't use the Muse and the Muse as a tool assessment for diagnosing patients with sepsis. Moving to the management of septic shock. So we are going to start with a study. So the RIVER study in 2001 evaluated the efficacy of early goal-directed therapy before admission to the intensive care unit. Patients who presented with severe sepsis or septic shock were randomly assigned to receive either 6 hours of early goal-directed therapy or standard therapy before admission to the intensive care unit. The goal of the study, or the goal of the resuscitation, was to achieve a hemodynamic stability within 6 hours, and that was defined by the following. a MAP greater than 65, a urine output greater than 0.5 milliliter per kilo per hour, and a central venous pressure greater than 8 all the way to 12. Now, the finding of this study was that the early goal-directed therapy provides significant benefits with respect to the outcomes in patients with severe sepsis and septic shock, and mortality. And mortality was only at 30.5% in the early resuscitation group, compared to 46.5% in the standard group, with a clinical significant p-value as well noted on the slide. So just to summarize the stepwise approach in sepsis patients. So number one, we need to support the blood pressure, and that is by providing fluids as number one treatment. If that is inadequate, then we can add on vasopressors and steroids eventually. We also have to think about source control, and that would be by identifying the source of infection and applying broad-spectrum antibiotics as soon as possible. Mechanical ventilation can be considered to protect the airways in severe cases. Renal support, which we can utilize dialysis sometimes in those patients that present with sepsis. As we mentioned, sepsis is a disease that target and cause dysfunction to multiple systems or organ systems in the body, including the renal one. And finally, we need to also control the glucose. So we're going to be discussing later about the sugar trial that also direct us to control the blood glucose and have a target of 140 to 180 milligram per deciliter in the hospital. So the goal of resuscitation, as it's just to sum up, we are aiming to a MAP equals to or greater than 65, a urine output greater than 0.5 milliliter per kilogram per hour. And also we are going to decrease the lactate level that patients in septic shock usually present with. And finally, to improve the organ perfusion. So the 1 hour bundle, the 1 hour sepsis bundle is a set of interventions aimed at rapidly treating patients with sepsis or septic shock within the first hour of diagnosis. These interventions are designed to improve outcomes by addressing the critical aspect of sepsis management promptly, and they are listed below. So number one, we're going to measure the lactate level and remeasure if initial lactate is greater than 2 millimole per liter. Number two, we're going to obtain blood cultures prior to administer the antibiotics, if able. Number three, administer broad spectrum antibiotics. Moving to four, we're going to administer the 30 milliliter per kilogram of crystalloid fluids for a MAP for patients who present with a MAP less than 65 or lactate greater than 4. And finally, we're going to initiate vasopressors if hypotension persists during or after the fluid resuscitation to maintain a goal of a MAP greater or equal to 65. And this is the structural bundle of the sepsis guidelines that they come up with in the 2021 updates. And that will bring us to our second assessment question of today's presentation. Which of the following is not a goal of resuscitation? And I'll give you a few moments as well to think about the answer choices you have, and we will move forward. So our answer for this question will be normothermia. As we discussed earlier, our goal of resuscitation will be aiming for a MAP greater or equals to 65, decrease the lactate level that usually patients present with, which is elevated, and finally improve organ perfusion. Normothermia is not a target of resuscitation. Moving to the treatment approach, starting with the fluid resuscitation. Okay, so for the volume of administration for patients with sepsis, and this is going to be repeated honestly throughout the presentation, for patients with sepsis-induced hypoperfusion or septic shock, we need to have at least 30 milliliter per kilogram of IV crystalloids to be administered in the first 3 hours of resuscitation. Now we have multiple choices or multiple agents to choose from. However, we have a study that compared LR to NS, and they found out that LR is preferred over NS as it has modest improvements in mortality and renal failure compared to the non-balanced crystalloids, which is defined as NS. And moving to the next slide, we're going to have that study we're going to discuss this study. So the trial name is NS versus lactate ringer for fluids resuscitation in adults, sepsis in adult sepsis patients in emergency medical services. The method of this study was an open-label randomized controlled trial undertaken in emergency medical services at a tertiary care teaching hospital. We had a total of 160 adult patients with a SOFA score equals to or greater than 2, and those patients will split evenly to receive 80 NS and LR, 80 patients in each group. The primary outcome was to find out the incidence of hyperchloremia at 24 hours from the time of randomization and during the hospital stay. The secondary outcomes were the incidence of acute kidney injury, the need of renal replacement therapy, the differences in pH, bicarbonate, serum lactate, coagulation parameters, sequential organ failure assessment scores at various times and points, and then lastly, hospital 30-day mortality. So moving to the results for the primary outcome, they found out at 24 and 48 hour post-randomization, the incidence of hyperchloremia was significantly higher in the NS group. So highlighting the red values on the screen or in the chart at 24 hours, we had 75% of those patients who received saline compared to 48.8% in the LR who experienced the hyperchloremia, and we noted a significant p-value. At 48 hours, we also had 77.2% in the saline group who experienced hyperchloremia compared to 60.3% in the LR group, and also we found a significant p-value. There were no differences in the incidence of hyperchloremia during the hospital stay otherwise. For the secondary outcomes, the acute kidney injury incidence at 24 and 48 hours post-randomization was significantly higher also in the NS group compared to the LR. So we had 23.8% of those patients who received NS experienced AKI or acute kidney injury compared to 10% of those with the LR. And then we had at 48 hours, we had 29.1% of the saline group compared to 15.4% in the LR group that had an incident of the AKI as well, or acute kidney injury, with both had a significant p-value. And there were no significant differences in the other secondary outcomes that we discussed in the previous slide. And that will bring us to the conclusion of this study that higher incidence of the hyperchloremia and higher rates of acute kidney injury were noted at 24 and 48 hours after randomization in the NS group compared to the LR group. Fluid administration is very important in the sepsis and in septic patients. So number one, we are aiming to have a large pore peripheral access that is preferred over central line for fluid administration. We may need to use a pressure bag to speed up the administration and the delivery of these fluids and support the MAP target. We administer each liter over 10 minutes, and we also can assess the fluid responsiveness, the MAP, and the urine output. And lastly, we administer more fluids as needed if we are not achieving the targeted MAP goal. So we are going to compare the crystalloids versus colloids. Colloids, as we mentioned, we have multiple options to choose from. So colloids, which are defined as albumin, hydroxyl ethyl starches, and dextran. They are not proven to be superior to crystalloids. There are so many studies that did not prove the superiority of these agents to be used in septic patients over crystalloids. And they have a little bit more downsides as they are expensive. The hydroxyethyl starches specifically increases the risk of renal failure and mortality. Dextran itself increases the risk of bleeding and anaphylaxis. However, albumin, which is known forever now, albumin is suggested for patients who receive large volume of crystalloids without any adequate responses. So we may consider at the end after, giving multiple boluses of fluids for patients in sepsis. And it also can be considered as a useful agent in liver cirrhosis patients and spontaneous bacterial peritonitis as well. And from here, I will leave it to Dr. Lama to take over. Thank you so much.
So I'm gonna give you an example. So if we have a 70-kilo patient admitted with septic shock, so we give 2 liters of lactated Ringer's IV fluid, and the blood pressure improves to a MAP of 65, and after an hour, the MAP decreases. So now we give another liter of lactated ringers and start norepinephrine. Now you have to think to yourself, should I give more fluids? So in order to do that, we need to assess the responsiveness to fluids by the patient. There are multiple ways to do that. It can be by physical exam, by static measures of cardiac preload, and by dynamic measures, which are the best method. Physical exam includes assessing the capillary refill time, the temperature of the extremities, and skin modeling. Static measures of cardiac preload include central venous pressure, which can be variable, and pulmonary artery occlusion pressure. And this is require an invasive procedure where we would have to insert a Swan-Ganz catheter that is risky and is also invasive. So we usually don't do that. So dynamic measures are the best methods. And these can be assessed by various ways. First is the passive leg raise with assessment of cardiac output measurement. So in this situation, we would lie the patient flat in the supine position, and then we would lift both legs of the patient. So by lifting both legs of the patient, this was expected to increase the fluid that is going to the upper body by 250 to 500 mLs. So if the blood pressure at our MAP increase by this method, then we can say the patient does respond to fluid. So we need to give more fluids to the patient. The next assessment is by giving fluid challenges against the stroke volume or pulse pressure. So in this situation, we would check what is the difference between the systolic and diastolic blood pressure. We give a fluid challenge, and if that difference between systolic and diastolic blood pressure decreases, then that means that the patient is responsive to fluids and the patient needs fluids. The third option is increases in stroke volume in response to challenges in intrathoracic pressure, which is the respiratory variations. So in this case, the patient would be intubated on positive pressure ventilation, and positive pressure ventilation increases the intrathoracic pressure. So if we increase the pressure by increasing the PEEP, and we see a drop in the blood pressure, that means the right ventricle is empty and the patient will probably need more fluids. If we increase the pressure and blood pressure increases, then that likely represents that we have left ventricular failure. And the fourth option is to consider using point-of-care ultrasound. And this is really great. Point-of-care ultrasound, we can measure the inferior vena cava to see if there are collapsible vessels. If the vessels collapse, that means there's not enough intravascular fluids and we need to give more fluids. And we can also measure the heart rate, cardiac contractility, and ejection fraction of the heart. So dynamic measures have been shown to decrease mortality, decrease ICU length of stay, and decrease the duration of mechanical ventilation. Next, we're going to talk about vasopressors. We know the mean arterial pressure equation is cardiac output times systemic vascular resistance plus central venous pressure. And cardiac output is the heart rate times the stroke volume. So in septic shock, we need to increase the MAP by affecting increasing cardiac output, systemic vascular resistance, and central venous pressure. So clinically, we cannot measure the MAP because we cannot measure the systemic vascular resistance. So we estimate the MAP by using 2 times the diastolic blood pressure plus the systolic blood pressure divided by 3. Normal MAP is 70 to 100. Our goal in septic shock is a MAP of 65 or greater. I'm going to review some receptor physiology. Alpha-1 receptors are found in the peripheral blood vessels, and stimulation of alpha-1 receptors will cause vasoconstriction. Beta-1 receptors are found in the heart, and stimulation will increase contractility and increase the heart rate. Beta-2 receptors are found in the blood vessels and bronchial airway, so stimulation of beta-2 would result in vasodilation, that means a lowering blood pressure, and also causes bronchodilation. We're going to discuss the various receptors and the effect of various pressors. So first we'll start with norepinephrine, and you can see the plus sign. If you have 3 pluses, that means this is a greater magnitude than 2 pluses. So norepinephrine primarily works on alpha-1 receptor, and it also has beta-1 activity. So norepinephrine is going to increase systemic vascular resistance and MAP, and it will also increase cardiac output and heart rate. So adverse effects include tachycardia, and in high doses, you may see peripheral and GI ischemia. Phenylephrine is a pure alpha-1 agonist. So the only thing it will do is increase the systemic vascular resistance and MAP, and it may result in reflex bradycardia. Epinephrine is dependent on the dose. Low doses of epinephrine, less than 0.05 mics per kilo per minute, primarily act as beta-1 agonist and beta-2 agonist. Higher doses of epinephrine, greater than 0.05 mics per kilo per minute, will have more alpha-1 agonist activity, and it will also have beta-1 agonist and beta-2 agonist. So the result of that will be increase in systemic vascular resistance and MAP, and also increase in the cardiac output and heart rate. Now, it's important to note that higher doses of epinephrine will increase lactate levels. Dopamine depends on the dosage, affects different receptors. Low dosage of dopamine at 2 to 5 mics per kilo per minute mainly affects the dopamine receptors. Medium dose, which is 5 to 10 mics per kilo per minute, primarily act on the beta-1 agonism. It also has a little bit of alpha-1, beta-2, and dopaminergic receptors. So this will increase systemic vascular resistance and MAP and increase the cardiac output and heart rate. High doses of dopamine, which is greater than 10 mics per kilo per minute, will have more alpha-1 agonism, and this will increase systemic vascular resistance and MAP, and it might be neutral or may decrease the cardiac output and heart rate. Vasopressin works on vasopressin receptors, and this will increase systemic vascular resistance and MAP. And high doses of vasopressin can cause cardiac or mesenteric ischemia and skin lesions. So for us, when we use vasopressin for septic shock, we use very, very small doses. Dobutamine primarily affects beta-1 agonism, and it also has beta-2 agonism. So dobutamine is going to decrease systemic vascular resistance because it is a vasodilator, and it will increase cardiac output and heart rate. So dobutamine would be a good agent to use in patients with heart failure, but not for patients in septic shock. And it can cause arrhythmias and hypotension. This slide represents the relative strength comparing the different pressors. So we see on the left side, the alpha activity, we have norepinephrine and epinephrine are stronger, have activity than dopamine and phenylephrine. And for beta-1 activity, epinephrine is stronger than dopamine, and that's stronger than norepinephrine. So in our vasoactive therapies, we need to target a MAP of 65 or greater. Norepinephrine is the first-line vasopressor that needs to be used. Then we can add vasopressin if the MAP is still low, if the MAP is still inadequate, with moderate norepinephrine doses. We may use peripheral access if central access is not available initially until we place a central line. But peripheral access really should be limited in terms of hours, and it's recommended to be less than 6 hours. And in some cases, they have been used up to 24 hours, but you have to do continuous monitoring. And it needs to be in a vein that is in or proximal to the antecubital fossa. Norepinephrine is the first-line agent per the Surviving Sepsis Campaign guidelines. It has less arrhythmias and tachycardia than dopamine and epinephrine. Initial dose is 0.05 to 0.15 micrograms per kilo per minute, and this is titrated to our goal MAP. So usual dosing range is between 0.025 to 1 micrograms per kilo per minute, with a maximum range for refractory shock of 1 to 3.3 mics per kilo per minute. Some hospitals use norepinephrine in the dosage that is in micrograms per minute. So if we use in micrograms per minute, we start at 4 micrograms per minute, and we titrate up every 5 to 15 minutes to a MAP of 65. Usually, concentration of norepinephrine is 8 milligrams in 250 mLs of D5W, and we can make bigger concentrations and bigger size bags based on the patient requirements. Side effects include infusion site extravasation and peripheral ischemia. Vasopressin is recommended to be added to norepinephrine if the target MAP is not achieved with moderate to high doses requirements. And that means if our norepinephrine dose is like 16 to 20 micrograms per minute or greater than 0.25 micrograms per kilo per minute. But the vasopressin dose is a fixed dose, and it's a very small dose, is 0.03 units per minute as an IV infusion, and this is added to norepinephrine, and this is not titratable. The usual mixing is 20 units of vasopressin in 50 to 100 mLs of normal saline, and we may start peripherally until a central line is placed. Some of the side effects include atrial fibrillation, bradycardia, and renal insufficiency. This is our algorithm for the vasopressors. Norepinephrine is the first line. So we start norepinephrine and target a MAP of 65. Then we add vasopressin if the MAP is inadequate and there are high pressor requirements. We can also consider adding dopamine or switching to epinephrine if there is cardiac dysfunction with persistent hypoperfusion despite adequate volume status and blood pressure. Our third assessment question: which of these is the preferred vasopressor in septic shock? And I hope everybody's going to answer norepinephrine, because we've said that multiple times. And next, we're going to discuss an antibiotic in septic shock. So in this study by Kumar et al., you see the graph, the x-axis is time in hours versus the y-axis, which is the odds ratio of death. So you see from the graph is that the longer we wait to administer the antibiotics, the higher the mortality. So we need to administer effective IV antibiotic therapy within 1 hour of sepsis recognition. For each 1 hour delay in antibiotic administration, there is a 7.6% increase in mortality. So our approach to the antibiotics, we need to identify the source of the infection. So then we need to draw cultures. So we draw blood cultures, bronchial brush cultures, urine, and other bodily fluids where we suspect is the site of infection. If there are abscesses and empyema, those need to be drained. And we may need to perform surgery on the patient if the patient has fasciitis or mesenteric ischemia. The number one source of infections in septic shock are the lungs, followed by the urinary tract, followed by the abdomen, and followed by central lines. So first, we need to obtain cultures prior to initiation of antibiotics. However, if the patient has very small veins and we cannot obtain the blood cultures in time, then we need to start the antibiotics without waiting for the initial blood cultures. IV antibiotics should be administered as soon as possible and preferably within the 1 hour of recognition of sepsis. We need to start with empiric broad spectrum antibiotic that would consist of 2 to 3 antibiotics. We also need to consider adding antifungal therapy. And the patients who would be at risk for fungal infections include patients with abdominal surgery, patients on total parenteral nutrition, if they are immunosuppressed, or if they have long dwelling central lines. The combination of therapy is aimed at the most likely pathogens for initial management of septic shock. So for example, if the patient is presenting with community-acquired pneumonia, we need to choose the antibiotics for community-acquired pneumonia. And if the patient has been on the ventilator for a while and we think the patient now has ventilator-associated pneumonia, then our antibiotics are going to change to different antibiotics that target our microorganisms. We need to achieve source control as soon as possible. So if the patient has a long-standing central line and we think the central line is the source of the infection, that central line needs to be pulled and a new line needs to be placed. We can also consider the use of procalcitonin. Procalcitonin level of greater than 0.5 indicates the presence of bacterial infections. So we can use the procalcitonin level in conjunction with our clinical evaluation to guide discontinuation of antibiotics when the optimal duration of therapy is not clear. Given the proper dose of antibiotics is important. In septic shock, there is high volume of distribution. So before beta-lactam antibiotics, we need to give high doses. Certain organisms that are also tend to be resistant, such as Pseudomonas, Acinetobacter, and Stenotrophomonas, also require high doses of antibiotics. High doses are also needed in the morbidly obese patients and if the patients have burns and open wounds, because they will be seeping fluids through the wounds. We can also consider using extended infusion beta-lactam. With that, our aim is to keep the antibiotic concentration above the minimum inhibitory concentration of the bacteria for an extended duration. As an example of that, we give the first dose of the antibiotic over 30 minutes, then each dose after that will be infused over 4 hours. Loading doses are recommended for vancomycin. The loading dose would be 20 to 25 milligrams per kilo. And we also need give a loading dose for aminoglycosides, such as tobramycin and amikacin. And if the patient has renal dysfunction or has low urine output, then we need to adjust the dose down based on the renal function and urine output. Next, we're going to talk about glucose control. We know that hyperglycemia is common in critical illness, and hyperglycemia increases the rate of infection and mortality. Our latest guidelines aims for a goal glucose of 140 to 180 milligrams per deciliter. This is the NICE sugar trial, which is a multi-center, non-blinded parallel group randomized controlled trial in 42 centers, included about 6,000 patients. And this included intensive glucose control, which is a goal of 81 to 108, versus conventional control with a glucose level less than 180. Primary outcome is death from any cause at 90 days, and also secondary outcomes are there. The results of this trial showed the 90-day mortality was higher in the intensive control. 27.5% of the intensive control died versus 24.9% in the conventional therapy. And that was statistically significant. For secondary outcomes, we see the hypoglycemia effect was greater in the patients who received intensive control, 6.8% versus 0.5%. So our conclusion is that intensive glucose control increased mortality among patients in the ICU. A blood glucose target of 180 resulted in lower mortality than did a target of 81 to 108. So our target is 140 to 180. We need to measure the glucose level via finger sticks every 4 to 6 hours. The best way to control the glucose levels is by using an insulin infusion, and this would be regular insulin infusion, 100 units in 100 mLs of normal saline, with a starting dose of 0.02 units per kilo per hour. Another option is to use correctional or sliding scale short-acting insulin every 4 to 6 hours, and insulin lispro is preferred over regular insulin. This is an example on how to titrate the insulin infusion if the glucose is high, greater than 180. And in this table is also an algorithm on how to titrate the insulin infusion if the glucose is low, less than 120. And for us, the nurses can titrate the insulin infusion by checking the glucose levels frequently and titrating it according to these tables. If the patient has severe hypoglycemia, a glucose of 40 to 70, first of all, we need to stop the insulin drip. If the patient can take oral, we can give milk, juice, or soda. If the patient cannot take oral, then we give 12.5 grams of dextrose, 50% as the IV push. And if there is no IV access, then we give 1 milligram of glucagon intramuscularly. Then recheck the glucose level and repeat every 20 minutes until the glucose level is greater than 100. Next, we're going to talk about the use of glucocorticoids, which is steroids. There are many trials for steroids in septic shock. So I chose to just talk about these trials to provide my point across. The first study is the adrenal study, which is a multi-center, double-blind, parallel group randomized controlled trial for about 3,600 patients. And that compared hydrocortisone, 200 milligrams per day as an infusion over 7 days versus placebo. The outcome is that in mechanically ventilated adults with septic shock currently receiving vasopressors, hydrocortisone 200 milligrams per day for 7 days did not reduce the 90-day mortality. It did shorten the time to reversal of shock. It decreased the days to discharge, decreased the duration of days on mechanical ventilation, and decreased the need for blood transfusions. And all of these were statistically significant. The second study is a comparison of early versus late initiation of hydrocortisone in patients in septic shock. This is a retrospective multi-center study in patients in septic shock who are already on vasopressors, and we add hydrocortisone, and the measurement is either starting hydrocortisone early, less than 12 hours, or starting it late, more than 12 hours from initiation of vasopressors. The results show that early initiation is associated with improved time to vasopressor discontinuation. It decreased the ICU length of stay, decreased the hospital length of stay, and there was no difference in overall mortality. So the main points for steroids in septic shock is that ACTH stimulation test, baseline cortisol levels are not recommended as predictors of patients' selection that may benefit from steroids. Hydrocortisone is the recommended agent for septic shock and ongoing requirements of pressors. We consider starting when the norepi or epinephrine requirements are greater than 0.25 micrograms per kilo per minute, which is about 16 to 20 micrograms per minute for at least 4 hours. The hydrocortisone dose that has been studied the most is 200 milligrams per day, given in divided doses. And there's no clear evidence of fludrocortisone's benefit, and fludrocortisone is a mineralocorticoid. For our next assessment question, what is the recommended dose of hydrocortisone for septic shock from these choices? And the answer is 50 milligrams IV Q6, which is 200 milligrams per day. So in summary, early identification and aggressive early resuscitation decreased mortality. Our goals is a MAP of 65, urine output of 0.5 mils per kilo per hour, decrease in lactate, and improving tissue perfusion or organ perfusion. Lactated ringers at 30 mLs per kilo is the preferred resuscitation fluid, and this is repeated as needed. Norepinephrine is the preferred vasopressor in septic shock. We add vasopressin at 0.03 units per minute, so this is a tiny dose that's not titratable. If the norepinephrine dose is greater than 0.25 mics per kilo per minute. We add hydrocortisone if the norepinephrine dose is greater than 0.25 mics per kilo per minute. We give IV antibiotics right away within 1 hour of diagnosis, and we need to control the glucose and to target a glucose level of 140 to 180. So now we will be happy to address any questions.
Until Dr. Ammar actually writes his question and he drops it in the chat, I just want to say something. أو رح أحكي بالعربي. هاي أول محاضرة لنا أنا والدكتورة لما، وأول مرة يعني كpharmacy assembly we're presenting such a thing to the SAMS Institute. ماهر أو الدكتور ماهر شعار اللي هو the president of the pharmacy assembly did add a link for the form. I think it's called استبيان على المحاضرة. فإذا لو سمحتوا يعني إذا فيكم تعبوا هذا الاستبيان أو I think it's a survey. وهذا الشيء بيساعدنا نحن بالمستقبل مثل ما ذكرت الدكتورة لما ببداية المحاضرة. نحن إن شاء الله حنكون عم نعمل أكثر من lecture moving forward and start getting mainly the pharmacotherapy aspect of treatments or like, you know, the medical team. فإذا تريدوا إنه تعبوا هذا الاستبيان and provide any recommendations to improve our future presentations, will be really appreciated. شكرا كتير. Okay, so we have a question from Hadil Haj. Can you repeat the idea of giving the procalcitonin? I think ordering the procalcitonin and using it as a parameter while treating choosing the antibiotics or escalating or de-escalating.
Okay, so I can answer that. Procalcitonin level, when it is high, that means there is an acute bacterial infection. So in the beginning, if we're not sure if the patient has bacterial infection or not, we can check a procalcitonin level. And we also start antibiotics until we get the result back. So if the procalcitonin level is low, that means there's no bacterial infection, but that does not exclude fungal infections, for example. So if we have the patient on antibiotics and we're not sure how long to give the antibiotics, how many days of therapy do we need, then we can check a procalcitonin. And if the procalcitonin comes back low or it decreased, over the days, that means that the patient responded to the antibiotics, and we can consider stopping the antibiotics along with our clinical evaluation.
صحيح. Precalcitonin, you can correct me, Dr. Lama, as well. I think the cutoff for the precalcitonin as well as an indicator for bacterial infection starts from 0.5.
Yes.
Anything below that is not considered a bacterial infection, and we need to think about other sources of infection, like could be fungal, could be other things.
Yeah, or it could be something that's not an infection, could be something else.
Correct. And also keeping in consideration what are the other factors that may affect the procalcitonin level also. If they end up coming back very elevated and patient has a renal disease, for example, and all that. So it's an extra parameter that we can use to help us escalate or de-escalate and treat the patient as well. We have another question from Dr. Ammar Ghanem. When you start vasopressors, do you start small dose and titrate up, or you start large doses and titrate down? When weaning off pressors, what is the order if you have multiple ones?
Okay, so when we start vasopressors, we said that norepinephrine is our vasopressor of choice. So we usually start with low doses and increase the dose every 5 to 15 minutes to a target MAP of 65. So if the MAP now becomes good, our MAP of 65 or greater, then, and we have added also norepinephrine and vasopressin, so we can start titrating down the dose. So first of all, we said vasopressin is a very tiny dose that is fixed dose. So we don't titrate vasopressin up or down, it stays as a fixed dose. Now, if let's say our norepinephrine dose is high, let's say 40 mics per minute, and we start titrating down the norepinephrine, if the MAP stays good, and let's say now our norepinephrine dose is down to 18 to 20 micrograms per minute, or less than 0.25 mics per kilo per minute, then we can hold the vasopressin and see if that will control the blood pressure. So if the blood pressure is fine when holding the vasopressin, then we start decreasing the norepinephrine, and we may need to stop the norepinephrine altogether if the blood pressure is fine.
I don't think there are any other questions in the chat. Please drop your questions in the chat if you have any further, or if you can raise your hand as well. And, if you have any questions as well, let us know. We'll give you a few more minutes.
And you can let us know, do you use vasopressin in your ICU?
Yes. That's another thing. We are presenting this presentation من America, so we're technically talking about what we have here in the United States. So that could also be a recommendation from you بالاستبيان, and what are the medications that you have also بسوريا and that you can utilize as well. That will help us as well.
Yeah. And you can also let us know what other topics you would like to learn about for intensive care topics. Thank you so much for attending our presentation today, and we will be holding more ICU topics coming up.
Inshallah. Shukran كتير. Thank you so much for all of your attendance. Inshallah, we'll see you in the future presentations we're going to be holding. موفقين جميعا.